in general, it's always better to be able to give an injection that kicks in right away and you don't need any oral coverage. But the reality is with risperidone, boy, oral coverage was really critical in microspheres. If you didn't do the oral coverage, the patient would fail easily before they even after 2 shots, they still haven't gotten the injection in. And then for some of the other medications, like some of the aripiprazole formulations, you still need to oral cover either 2 weeks or 4 weeks. Paliperidone has a real advantage because, like haloperidol, it can be loaded, so that patients can get 2 shots right at almost between as little as 4 days apart and have that high dose from the day they walk out of the hospital or for a couple of days after being given the injection in the clinics. So that can make a real big difference. We've even talked about sometimes using, when we transition from one injectable to another, making sure we continue that previous injectable for at least a month while we get that patient onto the new injectable. So understanding, and we really you need to really look at the details of each drug to really understand how you want to approach the patient.
And do you ever sort of offer patients, even when you're using a drug like paliperidone, offer them oral medication on an as-needed basis?
Absolutely. And we haven't said, again, another thing that I think most people who work with long-acting injectables know is that you always have to give a test dose of the medication. And so what is that? The problem is we have never been able to tell our clinical brethren, what is a test dose? It's as simple as one dose. Some people think you should take it for a few days. And what you're really trying to sort for is allergies. And honestly, I've never seen one, but it wouldn't be good to give an injectable and then have an allergy to it when you didn't give or at least one tolerability dose.
And it helps to know a little bit more about their tolerance for EPS and other dose-related side effects, because that may guide whether or not you need to modify the initial treatment initiation recommendations in a person who's particularly sensitive, or to cover them with a medication that's going to prevent EPS from emerging.
You raise a good point also on efficacy. These drugs do not translate directly from oral to injectable. So you have to kind of guess what would be the best dose for that patient. And the way I usually think about it is, if a patient's a low, medium, or high oral dosing patient, they're probably going to be a low, medium, or high injectable, with the provision that we've determined that they're low and medium and high oral, assuming they're taking it. And you don't know if you're, so it may turn out, this person's a high dose, risperidone oral patient. Well, really they're not. You're just giving a lot and they're not taking it very often. And so it turns out they don't have to take as much in the injectable because you know that they're taking it every day.